Novocure and lead all medical-related activities with a focus on our clinical trials. As a Chief Medical Officer, I feel very much inspired, of course, by our patient-forward mission. We cannot remind ourselves enough of the significant unmet needs that still exist for patients diagnosed with some of the most aggressive solid tumor cancers that we are treating and researching today. In our phase 3 trial in newly diagnosed GBM, EF14, Optune plus temozolomide showed superior efficacy and no significant increase in serious adverse events versus temozolomide alone. Tumor Treating Fields is now part of the NCCN Category 1 recommendation for newly diagnosed GBM, and is also endorsed in the consensus guidelines in 2020 by the Society for Neuro-Oncology and the European Association for Neuro-Oncology. Real-world evidence plays an increasingly important role in how we evaluate the safety and efficacy of drugs and devices to assess how they really perform in current day practice. So I want to highlight two important analyses for you today. First, with respect to safety, this publication in the Journal of Neuro-Oncology by Dr. Wen-Ying Shi, who will present later today, underscored Optune's safety profile with extensive real-world evidence. The investigators gathered safety data in over 11,000 patients and corroborated the overall tolerability of Optune therapy. No differences were observed between the total cohorts across regions, diagnosis, or age. This speaks to the treatment broad applicability in multiple GBM subpopulations, including the elderly. Here is a second important example of recently published real-world evidence. The authors of this publication analyzed data from the SEER database from 2005 to 2016. Their trend analysis showed that there was a significant increase in median survival for GBM patients and a significant time-dependent downward trend in hazard ratio. Interestingly, we see the trend break with a clear, observable increase in GBM survival in 2015 and 2016, the early years of the introduction of Optune, commercially with no other significant changes in the standard of care for GBM. And as proud as I am of the compelling evidence we have generated in GBM and more than 17,000 patients that we have treated today, we still have work to do to extend the reach of TTFields to many more cancer patients. Now, I'd like to shift attention to the other cancer indications currently in development. The numbers speak for themselves. When looking at the 5-year relative survival rate for some of the cancer that Novocure is actively studying, the task ahead of us is still very real. Despite recent advances, the unmet needs persist. We have principally set out to combine Tumor Treating Fields and have designed our trials to demonstrate clinical benefit of the existing standard of care, pursuing significantly improved overall survival as the primary endpoint in most of our clinical trials. You heard earlier today about the exciting preclinical work on Tumor Treating Fields, but I'd like to take a moment to highlight the promising phase 2 data that we have generated in the indications currently in development in our phase 3 pivotal trials. Across all of these phase 2 pilot studies, Tumor Treating Fields demonstrated an extension in overall survival when compared to historical controls without adding any systemic toxicity. Let me begin with our lung cancer program. The LUNAR study was designed to generate data that incorporates the evolving standard of care of patients with non-small cell lung cancer. The trial is testing the safety and effectiveness of Tumor Treating Fields with physicians' choice of immune checkpoint inhibitors or docetaxel for second-line treatment in patients who progress while on or after platinum-based therapy. The study is powered to measure an extension of survival by approximately 4 months, and we anticipate final data in 2023. In addition, we're also investigating the potential impact of Tumor Treating Fields in non-small cell lung cancer that has metastasized to the brain, building on our deep expertise in delivering Tumor Treating Fields to brain tumors. The METIS trial is testing the safety and effectiveness of stereotactic radiosurgery plus Tumor Treating Fields for patients with 1 to 10 brain metastases from non-small cell lung cancer. Because this trial focuses on a secondary tumor, METIS aims to extend time to intracranial progression by approximately 6 months. More recently, we entered into a clinical collaboration with a subsidiary of Merck, a global leader in oncology, to study Tumor Treating Fields in a phase 2 pilot trial with Keytruda in stage 3 first-line non-small cell lung cancer. This study represents the important expansion of Tumor Treating Fields clinical development into first-line stage 3 non-small cell lung cancer in comparison to second-line stage 4 treatment being studied in LUNAR. We're also running an abdominal cancer clinical program. I will leave most of the discussion on our pancreatic cancer trial to Dr. Babeker, who will be speaking after me. Allow me simply to highlight that the PANOVA-3 trial is powered to measure an extension in overall survival by approximately 5 months, and we anticipate final data in 2023. The INNOVATE-3 trial is testing the safety and effectiveness of tumor treating fields with paclitaxels in patients with platinum-resistant recurrent ovarian cancer. Nearly all patients with recurrent ovarian cancer develop platinum-resistant, and the prognosis for this population remains poor. The study is powered to measure an extension of overall survival by approximately 4 months, and we anticipate final data in 2023. In addition to these phase 3 pivotal trials, we're also investigating the safety and efficacy of tumor treating fields in 2 other very aggressive abdominal cancers, hepatocellular carcinoma and gastric adenocarcinoma. We have completed recruitment in our phase 2 HEPANOVA trial in liver cancer with data readout expected in Q1 2021. And the phase 2 trial in gastric cancer is currently enrolling patients in China in partnership with SciLab. We have established TT fields for the treatment of GBM, but we continue to push the boundaries of these GBM patients by exploring the potential impact of adding TT fields therapy earlier in the treatment paradigm. To do so, I am glad to announce that we have made significant progress towards opening the Trident study, which Dr. Shi will talk to you more about shortly. We plan to enroll 950 patients in Trident, making it one of the largest prospective trials in the field of glioblastoma ever to be undertaken. We expect first patient enrollment before the end of this year. Beyond our work in brain cancer, the thoracic and abdominal cancer programs are comprised of robust phase 2 and 3 clinical trials, broadening the potential scope of tumor treating fields application in the near future. I would like to state that the continued progress we make at Novocure to better understand these aggressive cancers and in many ways we can target them is only possible because of the company's unrelenting commitment to research. We see the map illustrate the many places where Novocure has partnerships and where independent research takes place to deepen our understanding of the potential of tumor treating fields to extend survival across multiple solid tumor cancers. Scientific progress cannot happen in isolation, and I believe that this day is a great tribute to our commitment to these invaluable external partnerships. It is now a great honor for me to introduce the next 3 speakers. Dr. Babiker from the University of Arizona will talk about how tumor treating fields can be combined with chemotherapy in the treatment of pancreatic cancer. Dr. Tran from the University of Florida will share his exciting investigational work on the combination of tumor treating fields and immune checkpoint inhibitors. And to conclude, Dr. Shi from Jefferson University in Philadelphia will talk about the potential synergistic effects of tumor treating fields with radiotherapy.
My name is Dr. Hani Babiker. I'm the director of the Early Phase Clinical Trials Program at the University of Arizona, and I am a phase 1 oncologist, and I'm also a GI oncologist with a focus in pancreatic cancer. For me, starting my career really earlier on, my interest was not only biology and medicine, but also physics. After my hematology oncology fellowship years ago, I had the opportunity to become a drug development scholar and work hand to hand with scientists and physicians that had a strong print in the treatment to fight cancer, including Dr. Van Hoff. And I remember a meeting where he discussed a new treatment modality that was exciting, which was tumor treatment electrical field. And that immediately grabbed my attention, given my strong interest in medicine and, as I mentioned previously, in physics. And hearing about this treatment modality, immediately captured my interest. You have a tumor treatment electrical fields that abrogate cancer cells division. It's almost like I remember the word that it uses, paclitaxel on a belt, meaning a treatment that is non-invasive and uses tumor treatment electrical fields to abrogate cancer cell division. And as you can see in that image in front of you is TTF affecting septrin and microtubules and hence leading to cancer cell death and apoptosis. Now, fast forward now, TTF is approved in GBM and malignant mesothelioma. Where really now it's actually coming back home is because I'm a GI oncologist with specific interest in pancreatic cancer. That interest actually accumulated to a project where we studied all the data outlined in TTF and led to a publication on clinical cancer research. Per the surveillance and epidemiology end results, currently the 5-year survival in pancreatic cancer is 10%. The PANOVA-2 trial was a trial that looked at a cohort of patients who were treated with gemcitabine and antimetabolite chemotherapy plus TTF, but also patients who had a Abraxane or Gem-nab-paclitaxel. The PANOVA-2 trial revealed a marked improvement in progression-free survival to the combination of TTF, gemcitabine, and nab-paclitaxel, with improvement in median PFS and median overall survival. In the 1-year survival for locally advanced pancreatic cancer of 87.5% and metastatic of 62.5%. So this really, actually, hit home where, combining medicine with physics, a new treatment modality that is outside chemotherapy, surgery, and radiation, and even immunotherapy that is really non-invasive. And now, not only in GBM and malignant mesothelioma, showing some efficacy in a cancer that has really poor survival and is aggressive, and it's really an unmet need in the world of oncology. This obviously was very exciting to GI oncologists, and that led to a randomized phase 3 international trial that is currently ongoing, looking at patients being treated with either standard of care gemcitabine and Abraxane versus TTF and gemcitabine and Abraxane. We're very excited about this trial. I look forward to see the results of this trial. Again, this is a treatment modality that is non-invasive. I'm an oncologist, and we give chemotherapy, and we see how patients have responses, but that chemotherapy also has some side effects. 80 to 85% of our patients present with either locally advanced unresectable or metastatic disease. There's no option for surgery. The conclusion I have from this is that looking back, I'm very excited. I was involved since 2015, and now moving forward 5 years, I'm still very interested. I think it's a modality that, for me, captures my interest, like I mentioned, in medicine, physics, and now pancreatic cancer. And I really look forward to some of the results of the PANOVA-3 trials. We've dubbed in our manuscript the TTF as the fourth treatment modality to fight cancer, and it's non-invasive and tolerable, and I really look forward to future results in this field.
Hello, my name is David Tran. I'm the Chief of Neuro-Oncology at the University of Florida. First, thank you so much for having me today. I'm happy to share with you some of the very, very exciting work that we have done with TTFields in the areas of cancer immunotherapy. I have been involved with TTFields now for the last 10 years, in 2010, very early day of the technology. And what we have observed over the years is that many patients who respond remarkably well to this technology tend to go through a phase where their tumor appear to swell up, look like it's progressing, but the patient continue to do very well. And these patients, over time, this inflammation beginning to subside, as shown here in the very typical appearance of a patient who go through this phase we call pseudo-progression because of TTFields. So the anti-mitotic MOA of TTFields, which is based mostly on apoptosis, which is a relatively inert mode of cell death, cannot explain this phenomenon completely. So we hypothesize that TTField must have induced tumor inflammation, perhaps by causing immunogenic cell death through a novel mechanism. Over the last 5 years, Novocure has supported our independent research. We are given complete independence in our pursuit of this mechanism, and they've proven this exciting hypothesis will have far-reaching impact in the future cancer immunotherapy, not only in GBM, but for many other solid cancer that TTFields are being tested on. We and others have observed that the anti-mitotic activity of TTFields can generate a large amount of abnormal chromosomes or DNAs in the cytoplasm. And also been known for a long time that abnormal accumulation of DNA in the cytoplasm is highly inflammatory. Nature has created multiple mechanisms to sense and eliminate these types of abnormal DNA, since the presence of this DNA tend to signal the presence of viral infection. So two very well-known DNA sensor systems are called cGAS and M2. You can see here that cGAS activate the STING pathways, which then in turn produce a large amount of pro-inflammatory cytokines and type 1 interferon response genes, which are very critical in producing adaptive immunity. On the other hand, M2 activate a completely different cascade, leading to the phenomenon called immunogenic cell death, where the entire contents of the cells spill out into the environment, creating a highly inflammatory phenomenon. And what we have shown is that TTFields can activate very robustly both of these pathways, creating a highly inflammatory environment inside the cells. So in essence, TTFields is an agonist, a dual agonist for both STING and M2. And because of that, we hypothesize that TTFields may be used to immunize patients against their own GBM. But first, we will successfully demonstrate that TTFields can produce anti-tumor immunity in animal models of GBM, as shown here in the diagram. And because of this observation, we hypothesize that if we combine TTFields with immune checkpoint inhibitors, that we would achieve very robust therapeutic synergy. Over the last several years, we have conducted a clinical trials testing this very concept in patients with newly diagnosed GBM, as shown here in the diagrams, where we combine the standard treatment for these patients with TTFields in addition to Keytruda, which is a immune checkpoint inhibitors. As of today, 20 of the 24 planned enrollments have been completed. We have observed clinically significant response. We are investigating the tumor-specific immune activation in these patients. And if the data confirm our hypothesis, this will have there will be a paradigm shift in how we approach therapy for these patients. Thank you very much for your attention. I'd be happy to answer any questions you may have in the Q&A session.
Thank you very much for this opportunity to present here. It is my great pleasure to discuss combining TTFields with radiation treatments. TTFields is the most recent FDA-approved therapeutic option for patients with GBM. There are many strong rationales to support the combination TTFields with radiation treatments, and this led to our initial investigation of this combination strategy. And we all know multidisciplinary approach is the most important and the most successful anti-cancer strategy. As a matter of fact, this strategy has been perfectly demonstrated in the management of GBM. Initially, surgery alone was the treatment used before the 70s. It has abysmal outcome. The overall survival is less than 6 months. Adding radiation treatment after surgery almost doubled overall survival. And as we all know, in the early 2000s, clinical trial demonstrating adding temozolomide with radiation treatment can further improve overall survival for over 2 months. Most recently, after chemoradiation treatment, combining TTFields with maintenance temozolomide make an even bigger stride in overall survival. Besides this, it's also from the EF11 and EF14 clinical trial as real-world experience, we know that earlier initiation of TTFields can lead to better survival benefits. And the longer use of TTFields can also improve overall survival. So combining radiation treatment with TTFields not only allow us to initiate the TTFields treatment sooner, but also will increase the usage time by at least 3 more months. Moreover, and probably most interesting and importantly, is there's substantial data indicating combining radiation treatment and TTFields can lead to synergistic effects. So based on this, combining TTFields and radiation treatment holds great promises improving outcome. The key issue we need to address for successful combination therapy is to avoid overlapping or dose-limiting toxicity. As we all know, the most significant toxicity from TTFields is skin irritation. Radiation treatment can also cause some skin irritation. So we need to come up with a strategy to address and avoid excessive skin toxicity. Fortunately, modern radiation treatment is precise and accurate, and we are able to protect the scalp as avoidance structure to use advanced radiation technology to minimize the skin radiation dose. And this approach is very feasible as demonstrated in the result from our early clinical trial. As you can see, even though the tumor is getting 60 gray of radiation treatment, the scalp dose actually can be kept very low. This will minimize or eliminate the radiation-induced skin irritation and make the combination therapy feasible. Currently, we already have clinical evidence to support the feasibility and the tolerability of such combination therapy. There are 2 published clinical trials reporting early safety data. Both have very consistent findings. There are common but very mild skin irritation, and this is not significant enough to result in radiation treatment interruption. Here are some of the pictures of one of our clinical trial patients who received radiation treatment while wearing the TTFields arrays. As you can see, and the radiation setup is perfect, and the patient can get radiation treatment without any issue while still wearing the TTFields arrays. Currently, both trials have only reported early survival data of 10 patients each, and these 2 studies were not designed to compare outcome. However, we do see a signal of favorable results when comparing to historical benchmark. As a clinician, each patient is an individual person to us. It is particularly meaningful for us to see positive impact we have on any patient. So please allow me to share a case to highlight this combination therapy. This is a 64-year-old previous healthy African-American male with newly diagnosed GBM. Unfortunately, as you can see on the right-hand panel, he has very infiltrated diffuse disease involving almost entire body. This is a phenomenon referred as gliomatosis. It is associated with particularly bad outcome. He's highly motivated and would like to have most aggressive treatment approach. So we enrolled him in our clinical trial. He started TTField treatment at the beginning of radiation treatment, and he has a perfect compliance to TTField treatment, as you can see from the treatment log. And he also encountered minimum or no toxicity. When he returned 1 month after finishing radiation treatment, the MRI scan showed a very definitive treatment response. As you can see, the previous diffuse involvement of the brain has resolved significantly with only a very small area of residual abnormality. More importantly, he continues to have a perfect performance status and leads a very normal life. and the recent follow-up continue to show excellent clinical response. And this is a case demonstrate the favorable clinical outcome, which is not expected from conventional treatment, and it provides great encouragement for patients as well as clinicians. Ultimately, clinical trial is the foundation of modern evidence-based medicine. Currently, we are very excited that a combination of TT-fused radiation treatment approach is being tested in a large international phase 3 randomized trial, EF32. This trial is recently activated in the US. This trial will further open in a total about 150 sites internationally. This is a superiority trial designed to test overall survival benefit of such combination strategy, and its results will provide highest level of evidence. We are very eager to support this trial and look forward to its results. Thank you very much.